everyone, and good evening to all of you. As you rightly said, today is a very poignant moment. We have lost not only the pain, but also it involves looking at it, losing our youngsters at BJ Medical College at the lunchtime. It was really heartbreaking when we when first heard the news, saw the news, and something obviously we will come to know the reasons for the crash, but it's a huge loss of face for the country as well as for all of us. We need to look into it, but nevertheless, thank you very much. And you had asked me a couple of earlier also, but somehow I had been busy. Today also I was in Chandigarh for a meeting, but and I just want to share is that the government is coming up with an antibiotic policy for the state sooner or later. That was the reason for the meeting, but I always enjoy. I can see all my friends, colleagues. I can see Dinesh is there, Dr. Law, Dr. Suresh Arora. I also saw Gajendra and so forth. So many people. It's just a pleasure to be with all of you here. But as you rightly said, the mood is little sad in what happened today. So if you permit me, I will share it and try to finish it off in next 25 to 30 minutes, because this is something we need to look into it. And as a physicians, all of us have been dealing with it. Though I have moved out from internal medicine, but the critical care has kept me, besides predominantly into internal medicine. And I always enjoy saying it that I'm internist by heart. So looking at it, this is something, at least my baptization of a couple of them was with the, to especially, is it audible?
Yeah, sir. Yeah.
Is it? Audible, can you see it?
Sir, go to previous.
Sir, I will just redo it. Yeah, I'll redo it. Screen दिख रहा है कि नहीं?
Screen is visible, but it is showing end of slideshow.
नहीं sir, मैं इसको okay. So let me go back. Just give me a minute. I think when I was doing that thing,
you have to go to the first slide.
Correct it. Give me a minute. I will just sort it out. अब दिख रहा है?
Yes, sir.
Okay. So over next 25 to 30 minutes, I shall be talking about tropical fever syndrome. I have little bit changed the topic and we'll be happy to answer the questions, and also we'll be happy to learn from your experiences which are there. I learned quite a few diseases by really baptization with fire, particularly scrub typhus. I will share it when I will come to there. But nevertheless, this is something which has been, we have been all looking at it now. Most of us are aware about it, but nevertheless, as you rightly pointed out, today, right at the peak of the summers, as the monsoon sets in, we will start seeing more and more of these cases. And with the molecular diagnostic tests coming up, cultures also, and non-culture techniques which are available, we are able to make the diagnosis of these conditions much more. So as a matter of fact, why are we talking about tropical infections? Because if you see it with the global warming, the area of tropics have gone up. It has been basically across the equator around 5 degrees was the subtropic, up to nearly right the Tropic of Cancer and Tropic of Capricorn, when we used to say that area was called the tropical area. But now today we are finding out that the diseases which we used to see during or in the plains or in the south have started shifting northward, and not only in India but across the world. And another thing which has been added to us is a lot of Indians are traveling. And therefore, earlier in the older era, before calling tropical infection, it was also called as a travel medicine. And that is why you will see it in the British time. It has been written that London School of Tropical Medicine and Hygiene, because That was the area which was called tropical. And also now today we see the number of people going to not only to Singapore, but also to extensively to Southeast Asia, Vietnam, Cambodia, and also Thailand. And similarly, we are traveling across both sides of the globe, equator. So a number of these things have started coming up, especially all of you are aware about malaria knowledge, which has been now first time reported in Odisha, which earlier was not. And it has been seen that it was brought by the people who have gone to the Southeast Asia. So it is very important for us. And when the person comes back after going to these places with the fever, not an uncommon thing, we need to evaluate. Similarly, a lot of these things were happening in the South India, which we never bothered about it. And we realized later on that it is not only the diseases of the agriculture India or the rural India, but also anybody who's getting exposed, especially mellidosis. Now you will see in the South, there are a number of centers, and even in the North, we have started finding it up, which we used to see it simply as a pneumonia, but now we know the diagnosis, especially in the diabetics. So there are certain clues. But whatever all said and done, these are the diseases which predominantly are vector-borne. These are the diseases which can easily spread also through respiration, like especially viral respiratory infections. Therefore, it is very important for us to look at the clues on the body that whether something has bitten or not, because that can help us up. And quite often we realize it, they simply come to you with a fever and we are wondering what is the cause of this fever. So tropical infection is a myriad of signs and symptoms. And therefore, to remember individually each condition is not easy, because some of them, if you remember your MBBS days, everywhere it was written fever, malaise, etc., and anoxia. How many conditions you can use? Most of the illnesses are associated with anoxia or other things. Therefore, it is important and fundamental for us to understand that these are the conditions when we are talking about are coming with the fever, and they can have a myriad or multiple manifestations, and that becomes a challenge for a physician. And as an internist, the biggest challenge for me actually is to diagnose a PUO. It has become much simpler, much easier today, but nevertheless, and one of the classical examples today, what has happened over a period of time, has been an amoebic liver abscess. I could see Dr. Dinesh Gupta and other colleagues. We didn't have a privilege to have an ultrasound at that time. Today, in fact, what we see today, the liver abscesses coming to us are the complicated ones, not the simple ones, which we were not able to diagnose earlier. Therefore, when you have a tropics, when it is there, when they come to you with the fever, then you say, okay, fever is there. Tropical fever, because the area where you are saying, or after travel, especially in the warmer climate when they come up. And please add to it now, Africa. Now we are seeing it, people going to New Zealand for the safaris, also going to Tanzania, and so on and so forth. So a number of these things have opened up with an Indian business opening up. So both occupational and recreational things have happened. So when the person comes during this period with the fever, so it becomes a tropical fever. And more so when you are able to make a diagnosis, then it becomes far more authentic. Syndrome means there is a constellation of symptoms. And when you find it out that somebody is coming to you can have a skin rash, or they may have altered sensorium, or they may have a jaundice. So you start looking at it. Where does it fit into it? Therefore, syndrome is not the illness. Syndrome is a combination of symptoms which are there on the basis of which we make and consider a differential diagnosis and make our approach for the management. And all of you are well seasoned people and are well aware of it. It's just to reinforce that idea that what we need to look at is a history, then we need to look at as a clinical examination, what is there, and try to fit into it with the history and physical examination. But what unfortunately I'm finding it up today is the practice of physical examination in large number, especially with the younger colleagues, has gone away. Please ensure it that this simple examination can give you a clue to the diagnosis on day one itself and can actually prevent or it can stop us from getting expensive medication and reducing the cost of management. And also it leads to far more gain in the patient confidence in his or her physician. Now, this is a very old data, but data is not very different. This is from my intensive care unit, and we have been doing, I will be coming to that also a little later. If you see it, when you looked at the 2 season and digital season, these are the number of, this 4th means the April, 5th means the June, 6th means July. If you see, this is on August. Maximum number of cases which we start looking it up, coming to us with the tropical syndrome. When we said ARDS, that means they're primarily coming to us with a hypoxemic type 1 respiratory failure. And when we say multi-organ dysfunction syndrome, it means 2 or more. Maximum number of these cases which we started seeing, it sees an uptrend trend in the months following monsoon. And obviously, you will see it also that here it has picked up in September right up to November. The illnesses which used to end up by the month of October, we are seeing right into the beginning of early December also because of the global warming. Therefore, we need to be very careful that with the global warming, the same pattern which we used to see, the illnesses for 2 to 3 months has expanded. The duration has gone up and they again have started coming up. Like similarly for the dengue or for the other things, we started seeing 2 peaks, like early phase, then with the mark heat when the mosquito goes, and then you start having when the rains come up, the temperature cools, again you start seeing the mosquito-borne diseases coming up. And the vector-borne disease, I said, is one of the major causes of these diseases, which could be mites, which could be mosquitoes, which could be flies. But here we are keeping it up primarily with the patients who are having a fever or with a multi-organ dysfunction, or who present to us in an emergency or even otherwise in an OPD with fever which has not been settling down. And I'm amazed at the number of tests which people are getting it done within 3 to 4 days. When we started looking at the etiology of the tropical infections, we found out dominantly with us, it was leptospirosis, rickettsia. Influenza also I've kept it here because in the respiratory infections, during monsoon, we see in this our country shows bimodal peak of influenza. One during the winter. This year, we had seen a very extended and a long tail of influenza, primarily of both influenza A, in which it included both H1N1 as well as H3N2. Along with it, we saw a number of cases of influenza B and subsequently coming up with pneumonia to us in the emergency as well as in the ICUs. And quite a few of these people, you must have realized, were having a persistent cough, which were there with the low-grade fever and ill health. When we got a CT done, we found evidences of bronchiolitis, we found evidences of non-specific pneumonias, which ultimately responded to. And I also remember that quite a few cases were referred to us for bronchoscopy for BAL, which actually was a bronchiolitis secondary to these respiratory viral infections. Malaria of late has gone down, but today in Chandigarh, where I was staying, one of the persons, the helper who was there, came with the report, Vivex positivity I saw after quite a long time. I'm certain you must have far more exposure because all of you are sitting in internal medicine OPD. And obviously, we need to look at the resistance patterns in malaria. And also we saw one young man suddenly coming us from Haridwar and Ayodhya. He had gone. He had a fever and then he had a black water fever, which practically I saw after 20 years. And he had a G6PD deficient. And what we found ultimately, Plasmodium falciparum, gave him artesunate and doxycycline, and the patient improved over. Therefore, you need to be careful about. So the syndromes help you picking it up, what it is likely to be. And obviously, we need also to know the sensitivity and specificity of the test as well. Now, these are the data which you published. I was part of it, which we got it published in 2020. And when the tropical fever was in an intensive care unit, because we see the severest of these cases. And this was a multi-center trial which was done throughout the country. And what we found, again, you will see the peak we are seeing is monthly distribution of these cases. And in these, again, August, September, that is the monsoon malady. That is one name we have been given up. And if you remember, sometimes people give a name which stick to it. If plague, fortunately, is not there anymore. But if you remember, old illness, it was called as a Kartik Wali Bimari. That was the month of Kartik when you have it. That was the time when the food was in abundance. Your grass was in abundance. Grains were there. So there was an increased rodent the population. And subsequently, one used to see that whenever mice will fall or the rats will fall, be careful about plague. That used to be one. Similarly, for the malaria or for your other mosquito-borne thing, those who have been from the civil service and they have worked in entomology posters there to look at the mosquitoes pattern which is there, because that forewarns the physician. Therefore, if you ask me today, the tropical fever syndrome for a clinical purposes is what we are discussing. But as a public health person, for me, it becomes a One Health incident. That means we need to interact with our people who are in the entomology, people who are in the veterinary, and people who are in the environmental sciences. So that gives us a fair amount of an idea that what is the likely chances of a disease in a place which is there. It leads to other things. We need also to know the epidemiology, because in pediatric age group, you will see a much higher incidence of Japanese encephalitis. And please remember one thing, a person comes to you with an acute paralysis, or person comes to you with the fever, with the flushing things, altered sensorium, or seizures, never ever forget rabies. We recently had 2 patients of rabies, dumb rabies, people trying to hide it up. We did the CSF, ultimately turning out to be rabies antibodies positive, lost both of them. So that is because you look at the population of canines which are there. So as a clinician, we need to be aware about it, and we need to see what is not fitting into it. I think that gives us an answer. And here what we found was a little difference is that dengue was the #1 condition with which patients have been admitted in intensive care units. And all of you have seen it, that dengue can be extremely severe when it bites, and when it spreads in numbers. Therefore, even 1 or 2% becomes a large number, as we saw in the COVID. But obviously, it does not spread as rapidly as we tend to see the patients of respiratory infection. It was followed by scrub typhus. Then we saw nearly, you see, 1/4 of the cases as a dengue, and another were 18%. These patients, we found out had a scrub typhus. We saw malaria. Sepsis was again not an uncommon factor, seeing it. Pneumonia is a small number. Leptospirosis again is far more common in different places, but we are seeing sewage workers, or we are seeing in our cities getting overflowed with the sewage water. And if somebody is gets involved into it, especially the legs become the site to get into it. And Bombay, you see very regularly this sort of an epidemic. Combinations were also seen. But remember one thing, in 1/5, we were not able to make a diagnosis. But nevertheless, today, it has become much easier for us because of molecular diagnostic tests to consider that or to make a diagnosis. Now, what are the common tropical infections? I have written from the intensive care unit, but this is again the tip of the iceberg, which you tend to see. Now, if you see it, malaria, again, it's a vector-borne, so is dengue. In between, we are seeing some cases suggestive of Zika. And also, you must remember that Japanese encephalitis, which happens in pediatric age group, is also mosquito-borne. Here we are trying to see in Aedes. Here we are saying to falciparum, again is plasmid. We are seeing it coming from the different group of mosquitoes. And there you have a culicine as well as other mosquito groups. Scrub typhus is again by the sugars or the mite bite. Enteric fever obviously is one thing which continues to be one of the most important culture positive thing. And everybody calls it कि local language में जी आपके यहाँ पे मोती जा रहा हो गया. But we need to see that every fever with the rash is not enteric fever. But what is important to remember is the Punjabi name of it, Miyadi Bukhar. To consider that it has a Miyad. Miyad means it has a outliers. So if it has a duration. If you see it after 3 weeks, then try to look for the alternate diagnostics. Leptospirosis has been taught to us the severest form is the Weil's disease, but nevertheless it is there. Along with an influenza, we need to add now an additional thing, that is the COVID and other respiratory viruses. We have seen with us all sort of respiratory viruses which are written in the book and which diagnostic things can know because of the availability. And these things come under the diagnosis of emerging viral diseases. Melanosis, anybody who is a diabetic comes with a pneumonia, septic, along with if you have a skin lesions, please do think about it. And in these are gram-negative cocobacilli, we need to ask the lab to give us the diagnosis. And of late, we are seeing few cases of Burkholderia also. But nevertheless, what is very important for us to know that the list is wide. But by and large, if we put them under certain syndromes, management and differentials become much easier. Now, mortality, I am talking in terms of it, nearly when they come to within advanced stages, that in our ICUs, mortality has been relatively high, though it is supposed to be much lesser. These are the patients of the severe or the extreme cases. Therefore, what we will wish is that most of these patients unless until say have a very rapid decline because of cytokine syndromes, we should be able to check it up right in our outpatient clinics, or at best when they are being referred before that. So there is a big time, except for the few cases where there could be abnormal immune response leading on to cytokine storm syndromes there, which can have a respiratory, which can have a cardiovascular manifestation, which we saw in COVID, which has a lot of cytokines getting released. Or sometimes when you start antibiotics, that will take you back to the pharmacology, where we used to have a Jerk-Simon reaction, especially in the leptospirosis or in syphilis. We used to talk about it. And sometimes there can be acute hemorrhagic things can happen in patients of meningococcemia, but we don't see that much meningococcemia. But you must remember, for the people who are returning from the Hajj, though in the Hajj you cannot go without meningococcus vaccination, but nevertheless we need to be aware. Or when our students are there in the halls or in the dormitories, or your soldiers, etc., who are staying there, please do remember that in favor with altered sensorium. So the challenge is, my dear friends, is the symptoms overlap and difficult clinical to identify them at the time of presentation. Person comes you with the 2 to 3 days of a fever, what to do? Most of the time you tend to wait. That quite a large number of them are viral illnesses and they tend to settle down. And most of the time when the viral illnesses, you do have an epidemiological data or evidence that this is happening. Then obviously some of these patients you need to start the outset, the empiric antibiotic, which one to use. Most of the time what we have seen is people are using either beta-lactams, or people are using oral beta-lactams, or people are using oral cephalosporins, or people are using beta-lactam inhibitors. And also what one is seeing is in a tendency now today to add up macrolides with it. But that is what I have written: hit wide and hit early. That's what, and hit hard. That is the additional thing which was taught to us in MBBS, still hold true for infective endocarditis. But what is the most important part, my dear friends, is that once you have antibiotics, you have started up, or you have a diagnosis, please de-escalate from broad spectrum, come to the narrow spectrum. And that's what is needed and required, because otherwise we are getting gradually into antibiotics which practically are becoming ineffective. So the primarily thing what we do is we identify the syndromes, and on the basis of those syndromes, we try to give them with an empirical treatment or a supportive care. Both things, they go hand in hand. When you start with the syndromic approach, you presume a differential diagnosis in your mind, write it on the file. We try to give them the treatment on the basis of that. And along with it, we give a supportive care in terms of fever control, in terms of your fluids, electrolytes, and nutrition. And then obviously we investigate, and once diagnosis is there, de-escalate. This is the standard triangle which is being used for the management of most of the diseases. But here we are talking in terms of syndromic approach, hence we are doing it. So there can be various presentations of tropical fever syndrome. It's simple, and the most difficult and troublesome for us are the first two: acute undifferentiated febrile illness and multi-organ dysfunction syndrome. What has caused that? Similarly, we are getting fever with ARDS. Is it influenza? Is it a COVID? Is it other respiratory infection? Or it is a part of a systemic infection like we see in the scrub, where they are getting ARDS or leptospirosis. Similarly, patients who come to with a fever with thrombocytopenia, it does not mean that it is always going to be dengue. Other conditions are also associated with thrombocytopenia. Jaundice is another thing which we tend to see. Earlier, we used to think that in the pediatric age group, IgA happens. But today we are finding number of patients are coming to you with the fever, with the jaundice, are actually having a hepatitis A besides B or E, which is common. And along with it, we are also seeing that there are certain other viruses, the part and parcel of metabolic syndrome. Fever with altered sensorium is another thing which you need to see. Encephalopathy, either sepsis or because of primarily CNS involvement. And there can also be conditions, fever with renal failure. I have not written about it, but there is another condition which happens with any of them if they are not responding, or even they have been started with, they come up with what you call as an HLH, or what you call as a macrophage activation syndrome, or histolymphocytic syndromes, which can happen in these cases. I will come to that little later. So when you talk in terms of acute undifferentiated febrile illness, what defines it? That means you are not able to pinpoint to an organ system. And you realize that the patient has a fever, is looking toxic, he or she is looking toxic, and you are not able to pinpoint what is this there. You try to look at, there may be a mild generalized lymphadenopathy, maybe small liver spleen, at best. But usually you do not find any localization to the lungs, any localization to the CNS, or any localization to the kidneys. That is the pyelonephritis. These are the ones which are commonly common 2 or 3 places, or soft tissue infections. So you need to look at it. So it doesn't give us a clue about it. And the commonest causes are the ones which we see common. So the malaria is one part that you see. Typhoid is another one. And the common thing which we look at in enteric, it still continues to be very common thing. And looking at the type of the waters which are being supplied to us, the good practice point is that we use boiled water, but everybody can't have it. Sometimes if we eat with unwashed hands, fecal root, it is there. Positive blood culture is there, but practically every Indian, if you see, they come with the typhoid or other reports, sir, moti ja raha ho gaya, positive report everywhere. It is the rising titer which is important. One single serological test at that point of time, if it is a clinical syndrome, helps you. But remember one thing, it's always better to do 2 testing with quantitative assays so that you know that yes, this is a rising or a declining titer. HIV, though we are looking at up, but this will be differential for number of conditions which can come up. Dengue, leptospirosis, rickettsia is something which we need to look at it. And rickettsia, again, we look at scrub typhus commonly, but any fever with rash. And if you're finding more than 7 days, you need to look rickettsia and various things. That's a separate issue. They will all respond to, by and large, to doxycycline. But nevertheless, we look at it. Relapsing fever, you need to look at in these patients, the trench fever, which is called. This is what we need to look at in patients, especially who have a poor hygiene, who are coming to you, brought to you from the prisons, etc. and otherwise. These are the common condition list, can be long also. But by and large, here there is no localization, so the respiratory infections goes out. Similarly, you also tend to have patients who have a UTI or upper acute pyelonephritis, etc. They are also out of it. Now, what is the protocol which you need to look at in your OPDs or in your emergency department of acute differentiated field? It's a beautiful algorithm which is there. It probably is a copy of what we did it for the Indian Society of Critical Care. I will come to you. So first and foremost, you need to look at whether the person has a fever. So what is your sepsis? Sepsis means person has started having earlier we used to say fever, then you have MOD, sepsis syndrome, and so forth. Today we say when you say sepsis, that means person has an organ dysfunction which is there. And in these cases, you tend to look at the lactates, you look at the blood pressure. If you find there's a little low blood pressure, give a liter of a fluid. If patient improves, then probably this is sepsis, this is not a septic shock. And also, along with it, you may find organ dysfunction, but primarily here we tend to look at it 3 things. Here the blood pressure is there, what is the respiratory rate, what is the temperature, what are the leukocytosis, etc. And when you do a blood gases, you always look at lactate, what is happening, or any other organ thing. Any of these signs are there that this is a severe sepsis, and then you need to follow the sepsis protocol as per we have that surviving sepsis guidelines. But if it is not there, then you start looking at the localizing signs. If you have got a pneumonia, if you have got a pyelonephritis, you have got a neck rigidity, or you have got a soft tissue infection, you drain the infection site, or if it is not there, you appropriate antibiotic and supportive therapy. You look at the day of fever. When day 1 to 2, differ investigation. For first 2 days, don't do anything. Wait and see how the fever evolves. Most of the time, they are self-limiting. If fever persists, then if they're coming to you on day 3 or 4, go for the total blood count differentials. At this point of time, you should look for malaria parasite, preferably in a quantitative Buffy-coat, and urine is unfortunately most of the time we are seeing is not being done. That is something which we need to look. Presence of 1 to 2 or 3, 4 first cells, if no symptoms are there, then probably you need to look alternatively. Fever can cause transient nephritis and you can have these features. Therefore, what becomes important for us to look at there are the casts which are there or not. They are the ones, leukocyte casts, etc., which points towards that, or there is a microscopic hematuria, etc. And again, if there is a hematuria, please do ask them to tell you whether this gentleman or a lady having a dysbiotic RBCs or not. That tells you about the upper nephronal urea and can think in terms of vasculitis, besides other conditions. If you are looking at it here, when you are seeing the blood of 3 or 4, you can go for the blood cultures. If you want to go at blood culture third, fourth, that's your option. But after fifth, it is always better before you start an antibiotic that you take blood culture 10 ml sample, send it today to the lab. And usually with an automatic techniques, we are able to do it. And these techniques are good enough even when you have given antibiotics. And obviously then your clinical judgment, if you're finding for us, one of the commonest cause for this is typhoid fever. If Dr. Sanjeev Kapoor is here, he will remember it. That fourth day PET CT scan was done of one of the patients, which was referred to him. And it was nothing else but enteric fever. But by default, we saw the first time the PET CT in a patient of enteric fever, which is there. He was furious, I was furious, but that's how the practice is being done. We need to come that. But I hope sir is around. And you could see the intestine swollen up. You have a multiple lymph nodes at different places. And the family was told that probably you're dealing with lymphoma. And it was nothing else but an enteric fever. Therefore, investigation, if you get it done beyond a point, can have their own challenges. So then next patient comes up with the fever with ARDS. When I said it, infectious thing, you look at it. And in these cases, when ARDS is there, you need to look at both infectious, non-infectious in the enteric type. And the common causes, I said CAP, when you are looking at it, they will be usually lobar, segmental one, but they can be bilateral. We have clearly started seeing number of these cases, especially coming up to us with strep pneumoniae. If alcohol is there, then think in terms of Klebsiella too, besides pneumonia, strep pneumonia, and number of other organs. This is here, if you have a soft tissue infection, pneumonia, septic shock, think in terms of mellidosis as well. And obviously, other conditions can also present to you with the fever with ARDS. This could be dengue, this could be malaria, there could be intra-alveolar hemorrhage, this could be a late phenomena, typhoid if there is a multi-organ dysfunction. Leptospirosis is known to have a sudden onset alveolar hemorrhage and person starts gasping in second or third week of illness. Scrub typhus, again, you start seeing in second or third week of an illness, influenza and COVID and other respiratory viral infection, which can include human parapneumoviruses, or also you can see with RSV, the bronchiolitis, but there is dominant. These are the differentials which you need to come. I will not go into beyond the point. When you start looking for the differential etiology of tropical infections in ARDS, first and foremost, remember one thing, in malaria, it is a late feature. When patient starts improving, then they start getting it up. Therefore, it is important if it is early, forget about malaria. They are recovering from MODS, shortness of breath, crepitation, radiology will happen. But this is a very late phenomena. And along with it, you will find hepatorenal dysfunction. Usually, you tend to see it in patients of falciparum malaria. In leptospirosis, as I told you, it is the second week of illness dominantly. And suddenly you will see a person has a whiteout lung, severely gasping for the breath, or there is a persistent hypoxemia. There occurs a fall in the hemoglobin. And along with it, you will have marked tachypnea with the minimal hemoptysis. Alveolar hemorrhages are associated with least hemoptysis, whereas bronchial lesions are with the much more. That's why we see much more in TB. Therefore, any fall with the white shadows, you think in terms of alveolar hemorrhage. And obviously, when you scrub typhus, when it comes up, you will see it. It is a second illness. And what is very interesting is because it is an endothelitis. When there is an endothelitis, then you need to look at it that there will be a capillary leak syndrome. And that capillary leak syndrome also happens in the lung, which gets manifested. So we are doing a trial now with an ICMR. We are 8 centers which are published interest trial, the role of dexamethasone, 6 milligram into it. But still, we can't say we have just started up. Last year we did it. This year we are recruiting the patient and probably will give it. What is very important for us is for the scrub, please look for the eschar. Look at it, the areas which are hidden, which are humid and which are warm. That means scalp, that means natal cleft, that means under the breast in the females, in the axillas, and also in the thighs around the scrotum and that area. So please look at it. In my intensive care unit, now it is the nurses who do it better than my colleague, my fellows. Therefore, please ensure it that they are taken. That is the principle that you need to examine these patients completely naked once to find out that you don't miss anything to repent later. As far as the dengue is concerned, majority of the dengue should settle around the first week. Extended dengue or expanded dengue syndrome is also associated with bradycardia and capillary leak. You will have, if somebody has the warning signs, we need to be aware about the dengue. If somebody has a severe pain, and the best place to look for it is the oral cavity. They can, because it's a reticuloendothelial system, so they can have a significant enlargement of the tons of the tonsils, which is the palatine tonsils, which are there, along with the pharyngeal ones, which are at the back. That's one common thing which we tend to mess it up, is not uncommon. The liver enlargement can be there, severe capillary syndrome. Please never forget to do a Hess test, which is there, and you can always find out from there what is happening. And H1 is the early part of it. It's a continuum illness. COVID is a second week illness because that is because of immune phenomena. Here it is a viral pneumonia. There is a viral pneumonia, but there is an immune phenomena too. So another group which you tend to see is a fever with thrombocytopenia. Here you can have infectious, you can have non-infectious. Children you will see much more commonly with the viruses than the adult, except the dengue. But nevertheless, most of the infections which we are talking about, they can have it. But if you are having the fever with the thrombocytopenia, please look at a sepsis, dengue, complicated malaria, lepto, and rickettsiosis. And zoonotic illnesses and other tropical illnesses. In this case, sometimes people come up, you do a rapid diagnostic testing for the malaria, and you are reported, the lab consistently report to you that you are dealing with a falciparum. Please look at in terms of babesiosis, especially those people who have horses or those people who are in equestrian, etc. Out there keeping like Tonga wallas, etc. So if that is there, that diagnostic tests by dichotomy are helping us to making the diagnosis. As far as the hematological concern, macrophage activation syndrome is very important. Clinical syndrome in this or HLH, hemophagocytic lymphocytic histiocytic syndrome. Here you will tend to see that patient may have a thrombocytopenia, but more important we look at is not single but two. It can be bicytopenia in terms of leukopenia plus thrombocytopenia, or pneumonia with or anemia with low HB with leukopenia or thrombocytopenia. There are other things there. There are 8 clinical parameters we look there, out of which 5 at least should be there, which include splenomegaly, which include, you will tend to see, besides bicytopenias, you will have an elevated levels of OTPT. You can have a mild dysfunction of renal kidneys, and so on and so forth. These are the few important things. And when you do investigation, you find that triglyceride levels are more than 150. Some writes 250, but you start looking at it, and ferritin levels are going to be more than 500. But we see if you find that levels are high, patient is not responding, treatment is of primary disease, then you have to start thinking in terms. If you suspect MAS or HLH, there are slight differences, but practically what we are talking about, then you need to look in terms of need or requirement for either steroids or intravenous immunoglobulins not. And this is particularly relevant for typhoid. This is particularly relevant for the expanded dengue syndrome. These are the 2 conditions where we need to see very carefully, are we dealing, though it can be, these are secondary ones. There are other factors. I'm not talking about soluble interleukin receptor 2, etc., or do you do a molecular diagnostic? We are not going, but these clinical parameters can fit it and make a diagnosis. Now, this is what happens in the malaria. As patient improves, thrombocytopenia improves. As typhoid improves, this is improved. Most important is, it is the dengue which will give it you with the time it declines. And most of the time is when patient clinical symptom improves. That is the time. That means it is that biphasic or saddle phase infection, dengue presentation. So when person improves, then it is going to be there. Please do 2 things always: fundus examination for bleed and also the Hess test. Why I am saying so is fundus, because that is a reflection of CNS. It can let you know whether this person has a probability of ICM bleed or not. And along with it, when you start looking at Hess test, it will give you an idea about Hess test, whether capillary fragility is there or not. These are 2 simple bedside clinical testing. Unfortunately, we have forgotten. We must bring the back clinical medicine. Leptospirosis again improves, so is rickettsiosis. And obviously in drug fever, you can have it, especially people have been on linezolid, or patients have been put it on other penicillin group of drugs. People also, if you're seeing sometimes with the heparin, if somebody has put it up, they can have a very rapid decline, including with the low molecular weight heparin. This is another group which tends to come up. Here you start thinking in terms, please look always in terms of neck rigidity or in terms of Kernig's or Budinsky's signs, which are very relevant, but in elderly, be careful. Any small alteration can lead you to encephalopathy. So septic encephalopathy is also important. If seizure is there, you are reasonably certain. Therefore, if there is a prior meningitis, you will not see altered sensorium. But if there is a meningoencephalitis, then you will see seizures and along with altered sensorium. And you look at, there's a huge list. If you're finding pneumonia along with the bacteria, with the meningitis, then the diagnosis is likely either to be streptococcus or other things. So that is how we look at it. Streptococcus is one thing which we saw. We saw this time a couple of different cases, but let's go by the classical teaching. And obviously, you always need to do a gram staining of the CSF, what we do, and find out. Tuberculosis is one part, but there is a longer history. Malaria, we have to obviously keep it in mind. Leptospirosis, you can always find it up. The other name for this is the typhus fever. If you see the typhoid and typhus means altered sensorium. That is why it is called up. So in the second and third week of infant, patients can have alteration of sensorium. And please remember all the exotic viruses. We have started seeing West Nile fever. We have seen Nipah fever. So Nipah viruses, etc. In Kerala, we have excellent surveillance programs. Therefore, we need to be careful. If you see from the same area number of cases that are coming, please do report to the health authorities. And in children, you need a Japanese encephalitis. And if you do a CT scan or an MRI, you will see thalamic involvement that goes in favor of it. Herpes always will remain if you're finding a temporal lobe signs, and the CT or the MRI is always important, will give you a clinical diagnosis. And that is there. You can start upfront. And obviously, you have to do the CSF. These are the ones, the data which has been published from PGI Chandigarh. Pyogenic meningitis is around, but tuberculosis continues to be there. We cannot ignore it. But when you use antibiotic and delay the CSF, it can create a problem. So you have to look at it. HSV encephalitis, dengue, probable viral meningeal encephalitis. We have to do a higher test. Today, we can do a film array or molecular diagnostic. We are doing it in all our cases, and we are picking it up, those which earlier we used to miss. And if you find any time the ADA level is high, it is not TB, it could be TB along with lymphocytosis. If it is there, please do look at viruses as well. Septic, I have talked to you about. Scrub, I have already done. And so everything which can come up. But remember, in elderly, sepsis itself, small thing which can tilt the balance and cause altered sensorium. Now, this is an algorithm for the patient with fever. Patient who has come to you with an altered sensorium, you look any drug, toxin, heat. Today, we must not forget the heat stroke. Today, temperature was 46. In the Haryana, we are seeing actually a heat wave, and orange conditions are there. So please never ever forget this thing. Get the CPK done along with it if it is elevated. Think primarily in terms of a heat stroke. Look at it, then treat according to the causes. If no, look at the clinical feature. Sudden onset, altered sensorium followed by fever. Then you need to look also at the localization. Not blindly we go for it. If localization is there, go for CT and other things. But if you find neck signs which are there, then obviously at that point of time, you will go for the CSF examination. Then history is acute, subacute, chronic. In these cases, usually subacute, acute, we usually take less than 48 hours or so. Subacute arbitrarily up to 2 weeks, and chronic may take a little longer time. And that is where if you find temporal lobe sign, think in terms of MRI, CSF, and do it. Another important thing which I will make to mention is, please never ever forget the sugar. Sugar, both more and less, can create a trouble. If you find hypoglycemia in pediatrics in particular, if you find there is a hypoglycemia, first thing I will do on any patient who's coming with, will do a blood sugar, see it. If it is low, correct it, see the response, then you follow this algorithm. If it is high, look for hyperosmolar and additional causes. If fever is altered sensorium, causes unclear, then obviously you start to do imaging, CSF, etc. And along with it, when you start looking at it, meningeal irritation signs, this is MES, is nothing else. So clinical evaluation is very, very important. And then followed by focal deficit. Only if focal deficit there, only then go for imaging. Otherwise, there is no need. Other two things which we have not had, we did not add at that time, which we are going to add now, is doing an ultrasonography of the eyes, where you look for the optic nerve sheath diameter along with the fundus. That will tell you whether there is an increased ICP or not. If it is not, no localization, you can safely go for CSF evaluation. If there is a localization, try to find out and see it, herpes is there or not. Control the pressures and then go for the CSF and treat and go according to that. If you have a meningeal signs, there is a plus minus focal deficit, because imaging maximum can tell you a brain is a basal meningitis, and along with CSF, that it is the CSF which will give finally the clue, the diagnostic towards the etiology which is there, which we need to do it. If you find everything is negative, look at electrolytes. What is happening to sodium? What is happening to calcium? Treat according to that. If sodium is low, treat it, but find out the cause, because hyponatremia is always secondary. And then fever with the jaundice, I've already talked to you, look for the hepatotropic viruses. Bacterial sepsis, malaria, if jaundice is there, it will be associated with elevated urea and creatinine. If it is a bacterial, if it is a hepatotropic viruses, it will be associated with the low. Therefore, it is very important with the low urea creatinine. So we need to put typhoid fever. It's a third week of the illness, we saw a couple of cases of typhoid and scrub, in particular in the younger group, in the children who came to us. Dengue shock syndrome, please remember, this is something very dangerous, which causes dengue expansion syndrome. And most of the time in the dengue, we see OT levels much more than PT. If they're more than 2 times, you find altered sensorium. Look for ferritin, look for macrophage activation syndrome. That is the time we need to see very carefully in these patients. Need to give FFP, or we need to give IVIG, or sometimes today we are looking and starting with cytokine therapies. And it has also been seen that when you want to give today platelets, whenever it is needed and required, probably FFP may be required if there is an alteration, and that is where the results are coming up to much better. And never ever forget another thing. Desi medication is becoming again a scourge, where people are coming to you with the liver failure. I will just quickly finish it off. So my dear friends, this is a differential thing which I put it up for you. Here the malaria CNS can be there. Lungs, liver, kidney, you can take this, and TLC is going to be high. In dengue, predominantly it is the involvement of the thrombocytopenia, fever, undifferentiated, and TLC is going to be low. So there will be leukopenia along with thrombocytopenia, which is the real, and paradoxically there will be hemoconcentration. So your hemoglobin and PCV will be much higher. In the leptospirosis, you can have a lung and a liver and a kidney. And when you have a lung and a liver and a kidney, that is what we look at the wheel syndrome. If you use a crystalline penicillin, nobody uses it today. That used to create much worsening, but never that is. But that was another spirochetes which was there. But in leptospirosis, you need to see hepatosplenomegaly again is common, and again TLC, usually leukocytosis is there. Typhus, we again the same. But what is very important is capillary leak syndrome is the commonest. Differentials for them comes of the TTP and HUS. Here you will commonly see in these patients you have a microthrombosis in this. So you will have basically a picture suggesting schistocytes, etc. So what you tend to see is a microangiopathic hemolytic anemia, which is going to be there. Typhoid, you will see small rashes. You put your hands on it, you will see erythema is there. In the fair skinned people, you can see rose spots, though we don't see as commonly. But what is very important is, please look at spleen or the liver have the same significance. And patient having the same pattern, the original step letter pattern, we don't see as usually, because the people start using antibiotics, which are there. And therefore, it is important that we must not miss typhoid, because most complication takes place in 2nd and 3rd week. Therefore, we need to prevent and treat it early. DIC, again, because of thrombocytopenia, will come in differential diagnosis, or per se, any of these conditions can itself lead to DIC. So please do check fibrinogen besides other things in these cases. A prospective multicentric study, again, the same we are talking in terms of it. The commonest what we saw in the syndromes was thrombocytopenia, followed by respiratory distress. Remember, respiratory distress is not only always ARDS, even severe acidosis can cause respiratory distress. Therefore, please do recall and remember that. Kidney failure is another one, encephalopathy, and obviously MODS. And here we lost 84 patients, which was nearly turning out to be around 18% of these cases. This was the real life data where we participated. But as far as the lab diagnosis is concerned, these all of you are well aware. Depending upon this, you will do it. Malaria, we need to look, microscopy still standards, gold standard. We are doing rapid diagnostic tests. But remember one thing, today we have to do only antigen-based testing, no enzyme-based testing. It has to be antigen-based testing. And in these cases, it's a very high sensitivity specificity. I started using these tests in 1996 when I gave it to my first postgraduate, Dr. Sriram Shivach, who retired now. And we first time used parasite TEF. lot of resistance, but now it has become the gold standard that we need. They have a high sensitivity specificity. So please do repeat it. If you have doubt, probably you need to be careful if you are using primarily enzyme-based, though government has banned that. Malaria thick smear is the one where you do parasite detection, thin smear species identification. Please remember this. Tell your labs to do both of them. And we are going gradually to the quantitative Buffy-Coat. And obviously, we are doing RDTs, which are antigen-based. And obviously, if you find 2 RDTs are negative, malaria is out, look for an alternate diagnosis. Typhoid, again, ideal gold standard is a culture taken within the first week when no antibiotic is given. Labs are good with the MALDI-TOF and automatic system. Practically, they are picked up. But nevertheless, when you look at the sensitivity of typhoid out is 79%, they have a good, they can rule it out better than Vidal. Vidal has no value today. Unless and until you look at it, you are looking for the Salmonella typhi, then look for O, paratyphi A and B. Rising titer is more important. But otherwise, I still say the culture, and if you want to supplement, typhoid out probably is one. Scrub Ashkar is the gold standard for the diagnosis. You don't need anything. Wheel Felix is a very specific test, but poor sensitivity. So today we are going on the point of control testing in these patients. Point of care testing, we are going there, which are extremely immunochromatographic testing on the bedside. If it is illness is more than 1 week, we are able to make diagnosis in more than 98% cases. That is how it has become the new one. But alternative is indirect fluorescence or RT-PCR from Ashkar or from the vessel is the major one. These are the Ashkar. You can see this is what you are seeing at the nape of the neck. This is what you are seeing on the scrotum. And this is what you are seeing on the inner thigh. This is our article which we got published in New England Journal of Medicine. And where we found out we used a composite primary outcome and the combination therapy was far better in terms of doxycycline, in terms of clinical relief, etc. But organ dysfunction had its own. When we looked at the calculated mortality and what we gave the combination, there was a 20% decline, but primarily use early. If the person is coming to you who is sick, use both of them, doxycycline and azithromycin. But if you have to use alone, then doxycycline, earlier problem was oral was available. Today, all of us have got intravenous doxycycline. Therefore, do not hesitate to use whenever you are in doubt. This is an excellent drug for the management of large number of these atypical infections. I'm not going into the detail. So the combination therapy with IV doxycycline and azithromycin was a better therapeutic option for the treatment of severe scrub typhus than monotherapy. So if you suspect scrub or prove scrub, use both of them. It will help you out. Dengue fever, again, I will not go into more of it. All of you are well aware about it, but we need to see what is the primary and secondary. In primary, IgM will be positive, but if you're finding IgM, IgG, it is a secondary dengue infection. But please be careful. The tendency to give platelet should be discouraged. I have seen people sometimes who are reasonable, maintaining the balance after giving the platelet infusion, jumbo platelet, have straightaway gone into pulmonary edema because of leaking capillary syndrome and myocarditis. The bradycardia is a sign of myocarditis. Leptospirosis, again, we usually go for IgM ELISAs. Specificity is very high, but we tend to see an ideal test is microscopic agglutination. It takes time, but nevertheless, if it is negative, it is ruled out. But good part is that a syndromic approach, the way we treat, most of them are treatment. Now, when you look at it, when you see that the patient has come to you, look at the airway breathing circulation. This is our guideline, which I have participated actively. In fact, Dr. Rungta is the lead author and I am the second author in it, along with Dr. Singhi. That is what has become now the gold standard algorithm for the management. We will going to make some changes in it now because of the availability of molecular diagnostic testing. But first you look at it whether a person has a sepsis or not. You try to identify the focus and localization, treat that. You assess the syndrome, consider risk factor, geography, season, and as well. Please don't forget diabetes as well as your, in these cases, immunosuppression. Fever with encephalopathy, we've already talked about that flowchart. I will not talk again. You look at the investigations which need to be done. Blood culture are mandatory in all of them. You do CBC, platelet, electrolyte, CRP, creatinine. We have not put PCT here. PCT will be elevated in these cases. So PCT is never used for the diagnosis. If you want to rule out, it's fair enough. Even in pneumonias and other, we don't use PCT. PCT only we use to look at the duration of antibiotic therapy. Therefore, procalcitonin Troponin should not be asked on the routine. Rapid diagnostic test must be performed on the bedside. Today, which used to take me 48 hours, the turnover time or the diagnostic time, if we do all these things, is less than 2 hours. And obviously, when you do H1 PCR, we send it for film array or we send it also for the RT-PCR. That takes time. But film array in our department, fortunately, we have a good coordination. Within 3 to 4 hours, we have all the results with us. One, you have suggested either if malaria is there, all of you know better than me. Artisanate, I have all dengue, you know, fluid supportive, typhoid, ceftriaxone we are using. And when you are looking at it, you are not sure. Start with the combination. You start with the ceftriaxone. Along with you do, instead of tablet doxycycline, use injectable doxycycline. Kidney failure, same doses. When you have a liver dysfunction, if it is because of disease, be a little careful in terms, because doxy is primarily metabolized by the liver. But if you give doxycycline orally, never ever give with food, never ever give with any milk product. There has to be at least difference of an hour before and after. And then obviously with the new data which is coming up, we are going to revise it. It has to be ceftriaxone plus doxycycline plus azithromycin as the first line treatment. And today with the enteric also, where we are seeing drug resistance coming up to the quinolones are useless today, all drugs sensitivity coming back. And with the ceftriaxone azithromycin, that is the combination we are using it up. It has a better outcome, which you can use for enteric. So practically you cover everything which is needed and required for the management. And supportive therapies, I think you are there. Agar bleeding is there, or the girls especially, it's a problem when they're menstruating. Use most of the time hormonal things. And then obviously, otherwise, if that is not, then you may have to use the platelet. No bleeding, don't do anything, wait, look for S test, look for the counts, then you go for it. And blood only and only and only if it is less than 8, not otherwise. ARDS, we will ventilate as per the NET protocol. Don't forget macrophage activation syndrome. Therefore, if patient is not responding or too toxic for you, look for serum ferritin, LDH, and triglyceride. These things are available. So high LDH, which is more than 200, triglyceride more than 150, and ferritin more than 500, you do it. I'm not talking in terms of calculated score, no need. Do bone marrow if needed or required. If you are sufficiently out of 5 clinical criteria there, I am comfortable. Diagnostics can be only confirmed with this. Steroids, if we find diffuse alveolar hemorrhage. In leptospirosis, if there is a hemorrhage, the drug of choice is methylprednisolone. Macrophage activation syndrome, again, drug of choice is steroids or intravenous immunoglobulins. And in the COVID-19, again, to use with remdesivir, we are using now much more early, and along with that, steroids. So platelet transfusion, I've already said, look for the risk factors which are there. Do not use, please, God's sake, less than 10,000, more than 10,000. It's a social pressure which comes to us. But we need to look at what is the risk. How will you do risk assessment? For the risk assessment, HES test and your fundoscopy is very good for you. Or if you find somebody has a nasal bleed or a gingival bleed, these are the people who are likely to have it. And along with it, if you have a danger signs of dengue, especially if you're finding liver dysfunction or there is an abnormal PT or PTTK, that is the time. In those cases, you may use plasma with platelets. So my dear friends, sorry, I've taken much longer time than have been allotted to me. Apologies for that. But a high index of suspicion is needed. Multiple diagnostic tests and modalities needs to be used. And aggressive line of management is required to tackle disease process and pathology. Guidelines here, we are only to help you up. In the field, it is you who are standing there and take a call. Thank you so much. And apologies for taking a longer time. Thank you.
Thank you, Dr. Dhruv sir. It was a masterly presentation as always. It was such a vast topic, and it was to be taking a lot more time. But you have really summed it up very nicely. And the key message, take home message is basically we need to apply syndromic approach to diagnose tropical fevers. We have to look at the signs and symptoms of tropical fevers in a very diligent way, and we have to try to fit them in various syndromes, because many of the tropical fevers, they definitely lend up to the diagnosis with the syndromic approach. And this syndromic approach has been very vividly illustrated by you. So if there is any question from any of the participant, they can unmute themselves and ask Professor Dhruva Chaudhry directly, or if they want, they can write in the chat box. I'll ask the questions on their behalf.
Good evening, Dr. Pawan. Good evening, Dr. Dhruv.
Good evening,
Hi,
bhai.
good evening, Ajay. How are you?
Fine, sir. Sir, about the enteric, you were telling typhoid, you were telling about the investigations being done. Vidal, you had said is less than the card tests. But the usually what the typhoid dot available nowadays is not the antigen based one, that is an antibody based one. So I think Vidal is more likely to be more specific and sensitive than that test, and specifically Vidal tube test.
You see,
And,
Vidal, most of the time we are doing a Vidal tube test. The problem is that it's a single test we're taking up the diagnostics. So it has to be, you see,
yes.
if you're having a rising titer, now everybody comes up with, sir, mera Vidal or typhoid order, mere moti jara ho gaya. Now, problem is that we need to use our clinical sense there. And serological tested, whenever you're using antigen-based are far more sensitive. But if you're using antibody-based testing, you need to have two pair of tests. You have to have a pair of tests. Sort of that they can suggest, but they cannot be definitive. That is why when we are looking in terms of diagnostics of enteric, they don't come up. Typhoid dot has been made primarily as a point of care testing, so that if you are there, you look at it. Now, IgG, if it is positive, it is not concerned to me. I'm more concerned about IgM. And in the IgM also, if it is positive, it stays positive for around about 6 months to 7 months. So I think what is important is we need quantitative assessment. And if it fits with the clinical profile, fair enough. That's all. I agree with you. But whatever we do, we need to be very careful what we are doing and why we are doing.
In cases of suspected enteric, should we go for a blood culture from the very beginning itself?
Answer is capital yes. But you see, first 2 days, you don't know what you are dealing with. Third, fourth, if persistence P fever, it is going up. That is why most of the time people tell you, because majority of the illnesses are viral illnesses, if you see it, they will settle down quickly. But if you are having a person consistently coming to you with a fever of more than 96 hours, it is absolutely essential to start antibiotics only after taking blood culture. And we are recommending, and the microbiology, also clinical microbiologists, all ID specialists, 2 pairs of cultures. अगर आपको याद हो, हम पहले लिया करते थे, एक लिया करते थे एंटेरिक ऑर्गेनिज्म के लिए, एक एरोबिक के लिए. Unfortunately, practices have gone away, and the time is coming that we are spinning it back. Now, what they have done is that instead of 5 ml, do 10 ml. And today, with the antibiotic, with automated systems, even if somebody is in a given, they have much higher sensitivity, specificity. I was looking at a blood culture in our institution also. Enteric continues to be number 1.
Right. That is what as far as the enteric is concerned, or rather, you are absolutely right that we can wait for the first 3 days. Even after 3 days, if the fever, high-grade fever is persisting, then before starting the antibiotic, we should take a blood culture. Sir, what have been the results of the blood culture sensitivity in enteric, which you have been seeing?
Quinolones, practically quinolones are resistant across the board. Chloramphenicol sensitivity we restarted seeing, and I'm seeing Dr. Gulati sir, I am seeing other colleagues or senior people also. So they should also, Dr. Punia is also there. So what we are finding it is that the sensitivity to cotrimoxazole has also started coming in some number of cases. Similarly, we are seeing within a chloramphenicol that this generation has not used chloramphenicol, so they are scared about it. With ceftriaxone also, sensitivity continues to be there, but it is slightly on the decline. Earlier, we used to have the results, so the doses have to be adequate. Sensitivity to ceftriaxone is there. Sensitivity to macrolide is also there. So these are the things which we are finding it up. But, pardon?
Aminoglycosides.
Aminoglycoside, usually they are not testing it up. We don't go for that. in routine.
So what we have been seeing in practice is that chloramphenicol is very effective, and especially in cases of the enteric fever with the lymph nodes diagnosed on the seen on ultrasound, we have been giving chloramphenicol. It is very effective, and I have used it even some patients having thrombocytopenia of 80,000, 1 lakh. And in those patients also, the chloramphenicol has improved as the fever subsides, the illness subsides, the thrombocytopenia has also improved. So
You see-
chloramphenicol is actually back, sir.
You see, chloramphenicol, I said it. You have used it. Dr. Gulati sir is there. I saw Dr. Marwa also. The people who are senior to us, they've all used chloramphenicol. You see, but because of the idiosyncratic reaction which happens in 1 in 50,000 so-called, that's why people are this generation has not used that antibiotic. That is why they are little scared of. But nevertheless, they are far more comfortable. So I completely agree with you. In fact, one of the scrub typhus patient, it was a child, we couldn't use it, so we used chloramphenicol. It was effective. That was the time before we came to know that azithromycin is effective. Therefore, judicious use, deliberate use is, there's no issues at all. There's no difference of opinion what you're saying. But one thing I will add is, because today you have availability of, or we have the availability of ultrasonography. Lymph nodes have been earlier also, because it's an enteric inflammation. You expect mesenteric nodes to be elevated. So it's all part and suggesting of that. You may have a small amount of ascites also, maybe some amount of an edema of the intestines also, which they can pick it up. So I think I'm not bothered unnecessarily. I go by the clinical thing. Labs sometimes or the tests sometimes it add confusion. I don't know whether Dr. Kapoor is there or not. One of the VIPs, the child, the daughter-in-law has been fever. They got recently married. Somebody went and they said, "Sorry, test kara." They got a PET CT done. Then I referred them to Sir Mega. You go and meet him. He called me. He says, "Who got the PET done?" I said, "Even I don't know, but the only thing is that I now know that how the PET inflammation in enteric looks like." So that was a way to do it. But point I'm saying is, still it is the clinical sense supported by appropriate lab test which decides majority of the cases.
Sir, in fever, the type of fever is again very, very important. And sometimes the simple CBC can point towards the diagnosis of enteric fever, because in differentials, there are certain pointers in diagnosis of typhoid fever. Like it is more of lymphocytosis, like there is absence of basophil, which is seen in enteric fever. So these pointers can also suggest that it is an enteric fever itself.
Very well said. Any leukocytosis takes me, or neutrophilia takes me away from enteric. Dr. Gulati sir is there. I would like to ask his comment, Dr. Punya or Dr. Kengan sir also. So that takes me away. I start looking for an That is where we start looking much more for the scrub typhus. If it's the same sort of a picture which starts coming up. Therefore, you have made a very good point. It made, I saw Dr. Gajendra Yadav also. And it also tells me that a clinician must be in touch with the lab, speak to the colleague in the lab. That is what gives you the maximum output in terms of, we regularly talk with our lab people. And sometimes they give us the clue when we are not looking at it.
Sir, there is one question from Dr. Surender that if there is no eschar, even then should we suspect typhus fever?
Answer is capital yes. 40% you show only eschar. Similarly, we see Indian rickettsial pox. We have also seen other conditions also. So 2-3 varieties are there, but dominantly is the scrub. Scrub means shrub. That's what is happening, and there is this mite and it come and bite you. Okay, but हम बोल देते कीड़ा काट गया या मकड़ी चल गई. This is all these things which is happening. Now today we have been able to know it. So mite-borne diseases are extremely common. So practically tropical fever dominantly are vector-borne diseases, if you see it.
Sir, probably eschar is the feature of only scrub typhus. Endemic typhus and epidemic typhus, they are probably not having eschar.
You see, malaria and typhus has a military history. If you look at the trench fever, you look at these people, a lot of troops in the Crimea and the Ukraine and Russia at that time died because of this. Therefore, I think we need to be aware about you need to be understanding about the military history, which tells us I learned about scrub typhus after burning my fingers, my hands. We thought we were in this impression that it never happens in our country. 2006, I got the first jolt when one of the colleagues' daughter, we gave everything except doxycycline because she was 14 years. And unfortunately, she died. One of the samples we sent, postmortem, we got it. Then another lady come with a digital infarct. And that's how my journey with journey with, especially with tropical medicine in particular, and with the scrub typhus started. So we presented in 2008, 18 cases in the intensive care ISSA meeting. And by 2013, you see number of people started talking about. And another clue, Dr. Gulati sir, I want to share came from Dr. Keshwani. One of the relatives had gone to Germany. There they grew Orientalis Tsugamushi. And this is how common. These are two things happened within a span of 2 weeks. We started looking and digging it up. Then we realized that we were using chloramphenicol as the management of typhoid fever. Chloramphenicol is an excellent drug against scrub typhus also. These are the true broad spectrum antibiotics. And then what we realized कि जब से उसको बंद किया और जब से आपका क्विनोलॉन शुरू हुआ टाइफाइड फीवर में, they stopped responding because we all thought that this is a typhoid, but it was a typhus. It was a rickettsiosis. So I wrote an editorial for it in the Indian Journal of Anesthesia, Resurgent of a Forgotten Killer. And then we looked at the history. History tells us in 30s, it was described. Then we looked at it, 4 military cadets died because of scrub typhus in Dehradun. They had gone for the excursion, 42-kilometer walk, and they came and they fell sick. Therefore, this is how we learned, we evolved, and that we are not talking about in terms of combination. The only thing I will say is, in pregnant patient, you cannot give doxycycline. There, neither you give chloramphenicol. Therefore, the drug of choice there continues to be today azithromycin, and along with it, you use rifampicin, 600 milligrams twice a day. In the pregnant females, if they have this thing, they should use this.
So there is one more query from my side. In our basics of antibiotic therapy, we used to study that we should not combine bacteriostatic drug with bactericidal drug. But now the combination of ceftriaxone with or other cephalosporins with the azithromycin is emerging. How can we justify this?
No. You see, azithromycin is a bactericide. It's not a bacteriostatic drug. The difference is, first of all, these two combinations should not be made. People making up jo marji karte rahe, but I think that is not justified. Azithromycin has a different mechanism of action. What azithromycin does is that it does not stay in the serum, in the blood. It goes and gets itself into the white cells, that is the macrophages dominantly.
Yeah.
And there it stays for up to 4 to 5 days. Therefore, it is a long half-life. That is why people said you give for 2 days, 3 days, etc., etc. So it works at that level. It is not a bacteriostatic drug. But whereas the clarithromycin has a significant value, significant serum presence, therefore in septic cases, which are with septic shock or bacteremia, clarithromycin is preferred over azithromycin. I think that distinction we need to be clear. Sometimes within the same group, drugs can have a different pharmacokinetics. I think that is very fundamental, which we need to be aware about. The only thing you need to be careful today, as far as azithro or clarithromycin is, if somebody has a long QTC interval or any other drug which can cause long QTC, combination it is there, it is dangerous, and be careful.
Perfect.
Dr. Dhruv, good evening. I am Dr. MP Jain.
Namaskar, sir.
And probably now the current generation, especially the postgraduate in last 10-15 years, I think they are forgetting about the malaria. And nowadays, in late 80s or early 90s, we used to say that every fever is a malaria until unless proven otherwise. But nowadays, I think malaria, neither even the pharmaceutical companies are also not making anti-malaria drugs. So that is, I think, probably a very bad sign and bad thing. So I think people like you, those who are in medical college, I think it must be emphasized during the clinical tutorials.
Sir, chloroquine is available. Similarly, artesunate, artemether, artesunate is available. And today itself, trust me, I had to write a prescription for pulmonary Vivax. I had to look at the doses because new combinations have come up today which are available. For me, it's very simple that if I have to write chloroquine, which is available, you have a double strength, you write it, 1000 milligram, then you follow it after another 500, and you give 500 per day for 2 days and get out of it. But then you have to write Primaquine. Availability of Primaquine sometimes have been otherwise in a challenge. So here what we are seeing is that now you have got like artemethyl lumefantrine combination, which books write 20, 120, but what is available is 80, and for it, it is an 80 and 480. So that becomes a challenge for us, because what you write, they write 4 tablets. So here it will be 1 tablet twice a day. So now you reduce the pill count. So that we need to look at. I agree with you that these drugs are essential list and are available. Similarly, injectable artesunate is readily available, which we tend to use it up. So that's the point. Another drug which I think should be available, which we have taken up with the drug controller also, is the crystalline penicillin. It's an excellent drug. Unfortunately, somehow because the cost is less, people are far more happy doing for the other drugs. So that's what we are feeling a challenge. But this old is still gold, provided important is that sensitivity pattern is there.
So good evening, sir. I'm Manish Jain, and first time coming over here in nephrology. So as Dr. MP Jain rightly said, yesterday I got a case on dialysis and with a falciparum positive. And outside, this lady was given Falcigo followed by Primaquine. Her hemoglobin has gone down from 9 to 6. So G6PD is sufficient. I got it done. And now again the falciparum has come positive and she is having fever. Her blood is low growing, Elizabeth also, and she is having Permacat. So what should we give now? I was asking Sushila today, because previously I used to consider malaria, but last 20 years I have not seen. So already she has received Falcigo and on Primaquine. So then I think combination should be given, or otherwise, what is the role of quinine now?
Manish, good evening. I am seeing much more your haath ki rekhaएं dekh raha hu teri. So you see, just first 2 things first. Basic thing is, has the lady received adequate amount of Falcigo or not, artesunate or not? That is point 1. Secondly, you need to add most of the time doxycycline to it when you are using it. This is the 2 combination therapies which we commonly use. 2. Third thing is, if there is a falciparum positive, is on what? Is it on slide or it is on your rapid diagnostic test?
It has come on antigen, and outside I think slide was given, so both the places.
You see, so the antigen will stay positive for a longer point of time. So what is important is that you get a thick smear, thin smear, find out the percentage point of it. Now this patient, if it is there, these are the patients which we used in the past. One of the theses which I had given at that time was the partial blood exchange transfusion. Now the question is, if it has gone down, that means there is an active hemolysis, there is a loss somewhere. That is what is happening. G6PD, when you will get it right down at this point of time, probability of low will be less because the younger things may come up. Therefore, what is extremely important is that we will not be able to give quinine. Now we have given Primaquine. So these are the drugs which are available with us. You can say cautiously, you can use quinine in these cases if it is not working, but I will simply not go by antigen test alone. I would like to see what is happening to the smears, because you expect log reduction by half in 48 hours of these cases in malaria.
Yes.
So I saw, that's what I said, we saw a young man coming up. We had to ventilate that patient. The drop of hemoglobin of 14 to 4, it was all intravenous hemolysis. And I don't know whether it is a patient on a dialysis or the patient has got a kidney failure now. What is it?
No, she's already on dialysis. She's already a dialysis.
That's fine. That's fine. Because what I was trying to look at it is that boy got a renal failure, but recovered quickly because it was all hemolysis which was leading on to it. It was a black water fever. I saw that black water fever myself after 20 years. I hadn't seen it. I think we can present that case sometime, and I've been trying to tell them. So the answer is that continue with arsenic if need to a little bit extent, and or if your antigen test, forget about. Now the problem with these tests is whether it is an antigen or antibody. Once it is positive, like CBNet we do in TB for the diagnosis, then you leave it. It has no use there after that. They will continue to be positive because of the presence of the DNA or RNA there.
Yes, sir.
So what is required is you look at the smears. That is what is required. Confirmation is there now that this patient has, so they justified. And the other drug on dialysis you can easily use actually is a doxycycline. So that is something which helps. Primaquine, ideally, people give it for very different reasons. That reasons for, correct me, Dr. Gulati sir and all, for Vivex, we have been giving it primarily for recurrent ones, cases, hepatic action, because the blood is taken care there, but because of the trophocytes which are there, they're in to take care of that. Here you are doing it as a gametocidal. There is a role of two different things. This is not for the patient. This is for the community. There, that is for the patient. Because otherwise they will keep Vivex where recurrences are known, recrudescences are known. Not recurrences are wrong word, recrudescence is a word which we use. So hepatic trophocytes, it works on. That is the reason for it. And you give there for 2.5 twice a day for 2 weeks.
2 weeks.
Here you don't give, here you give for 48 hours. There is a difference in the pattern which we see and we use it. So the answer to that is, सुशीला को ये कहना कि देशवाल को भी ये बोलना कि अपना इसका थिक स्मेयर कराओ, थिन कराओ, उसमें दिखता है तो ठीक है, नहीं तो नहीं.
नहीं, वो तो मैं ही करा लूंगा सर.
ठीक है. Madam is there, she can look into it.
Yes, sir. Thank you, sir. Thank you.
Good evening, Dr. Dhruv. Good evening.
सर प्रणाम.
और कैसे हैं?
सर बस बढ़िया सर.
I must compliment you for this very nice, excellent talk you have given on febrile illness. Just
Thank you,
2-3
sir.
comments I'd like to make. When we are dealing with such a fever, we must ask any recent history of travel. Because traveling to certain places may predispose you certain tropical diseases. So must include this in your history part. Any recent travel to any area where some certain diseases are more prominent, more common. Secondly, when we are stuck up, we don't find any region, we must keep those non-infectious diseases also in mind. We have seen many cases having high ESR, no other findings, ultimately turning out to be acute rheumatic illnesses like that. So these things should also be kept in mind when we are dealing with such patients with febrile illness. Thank you.
Thank you, sir. I think you have reinforced what I started with, that we need to take, because a lot of Indians are traveling now. And similarly, that's why you will see that on the one side we talk about ID, another side we talk about non-infectious. But we must not forget that is there. But in infectious disease, macrophage activation syndrome is something we must not forget. I have done 2 CPCs on it. And then along with it, we have now finding practically every day, 1 or 2 cases in a month, we are finding it up. Not only with this, but we are seeing it with the rheumatic disorders, we are seeing with other things. So probably with the more availability of the things, more awareness about it, we are able to do that. And that is where you will see it. And one of the most challenging things for us is an expanded dengue syndrome. And now the data is coming up because when we give platelets, we feel it works, but most of the time it doesn't. So the few now reports have come up where you tend to use it with a fresh frozen plasma and then you use with it, because you have to take it totally into it consideration what is happening, not alone. So इसीलिए वहां पे फिब्रिनोजन प्लस पीटीआई पीटीटी के या कई बार हम पीटी के लिए भी चले जाते हैं ताकि we have an idea कि क्या हो रहा है, and then according to that we go ahead with the treatment.
Thank you, Dr. Dhruv. Thank you for your nice presentation. And it was a really very nice, and the season is also coming up for all these fevers. And on behalf of IMA Haryana, I put a vote of thanks to you as well as to all the delegates, those who are still there and listening to this wonderful topic. Thank you, sir. Thank you so much.
Thank you so much, sir. Thank you. Thank you, sir. It was an honor. And the best part is I could see a lot of my friends. Dinesh, thank you so much. Dr. Punia, thank you so much. It's good to meet all the friends. Thank you, sir.
Thank you, sir. Thank you, everyone.
Good night, everyone.
Thank you, sir.
Thank you. Right, sir.
Right.
Thank you, Khanna sir. Namaskar.
Thank you and good night.
Good night.